Before we begin with Dr. Romano's talk about the Affordable Care Act and its impact on you, I'd like to tell you a short anecdote of a Medicare patient. Kolya emigrated from the Ukraine in 1980 and worked hard to build the American dream. He bought a house, raised a family, and in 2012 retired at the age of 65. He accumulated many of those things that other Americans tend to acquire as they pass through life, like heart disease, high cholesterol, diabetes, and hypertension, and of course polypharmacy. So at age 66, he goes to his doctor for a checkup. After the exam, Dr. McGreedy sits down rather solemnly in front of Kolya. I have some bad news. This is going to be our last visit together. I can no longer accept Medicare patients. Medicare reimburses so little that I just can't afford to take care of people like you. Kolya is stunned. But doctor, I've been your patient for 10 years. I trust you. You know my condition. I don't want to change doctors. What can I do? Stay your patient. I'm so sorry, Kolya, Dr. McGreedy replies. It's not just my decision. All the other members of my medical group feel the same way. We're going to concentrate on a younger patient population with better insurance reimbursement. Kolya thinks a moment. You know, doctor, I have heard that in these hard times, patients who lose insurance sometimes pay their doctors with goods or services. I got a little farm. I raise chickens, have a small garden. It keeps me and my wife busy, and we don't have to pay so much for food. How do you say? How about I give you 12 eggs a week? No, 24 eggs a week. And you stay my doctor. Dr. McGreedy shakes his head. Sorry, Kolya, I can't eat all that cholesterol. I follow a heart-healthy diet. Kolya taps his head knowingly. Znаю, I know. How about one plump chicken every other week? No red meat, just good, healthy white meat for you and your family. Sorry, Kolya, says Dr. McGreedy, again shaking his head. You know, you can't bring chickens in here. I can't risk contaminating the clinic with salmonella. Kolya is not to be put off. Hey, doctor, you like greens? I got the Brussels sprout green, I got the broccoli green, I got the kale green, I got the spinach green. I bring you big basket of green every week. This time Dr. McGreedy seems to be paying more attention. I do like some varieties of green. I wouldn't mind bunches of the Ulysses S. Grant green, and I'd really appreciate a basket full of the Ben Franklin green. Okay, anyway. So by way of that Medicare introduction, I'm delighted to present to you Dr. Patrick Romano, a dear colleague and professor of both internal medicine and pediatrics at UC Davis Medical School. Patrick is an internationally renowned expert in quality measures. And he's always jetting off to New York or Berlin or Paris to present to agencies like the Agency for Healthcare Research and Policy or the World Health Organization or the International Organization for Economic Cooperation and Development, and organizations whose acronyms I have no idea what they stand for. He is also busy in the internal medicine clinic where he teaches, as well as in the pediatrics clinic, and he's always running about. Patrick doesn't know how to walk. He runs from clinic to clinic everywhere within the office. Patrick runs back and forth among our offices in his stocking feet. It's true. It really is true. He is so peripatetic, but it's really delightful to be able to welcome Dr. Romano, who's going to talk to you about the Affordable Care Act and what it means for you. Dr. Romano, thank you very much.
Thank you, and good morning, everyone. All right, well, after that introduction, I hate to disappoint. So what I'm going to do is to give a little bit of background to how we got where we are today with the Affordable Care Act, so-called Obamacare. We're going to talk a little bit about the the context, if you will, behind the passage of this act. And then I'm going to focus more specifically on the provisions that relate to the Medicare program and the implications of those provisions for you and your family members as they will be implemented over the next several years. So first of all, this is, of course, no secret to anyone here, but we have seen a tremendous increase over the last 2 decades in the cost of health care in the United States. So now we're up to somewhere in the range of, according to the most recent data from 2012, $8,680 that's spent on health care for each man, woman, and child in the United States, on average. This represents 17.9% of our total gross domestic product. And of course, what's interesting is that not only is the spending on health care in the U.S. higher than in other developed countries, but the rate of increase has also been higher. So the black line shows the data for the U.S. The other lines show data from other developed countries, North America and Europe, as well as Japan. And you can see that the gap between where we are and where other countries are has gradually diverged over the last 20 years. So this is really an important context behind what Congress has been trying to do and really provided background for the Affordable Care Act. We also know that this is just one of the crises facing American health care. Another problem is that we're spending all this money, but we don't seem to be getting as much out of it as people in other countries. So this is a ranking of different developed countries. You can see Australia, Canada, Germany, the Netherlands, New Zealand, the UK, and the US. What the Organization for Economic Cooperation and Development does is to collect data using systematic procedures and benchmarks from these different countries regarding various aspects of health system performance. So you can see that in the traditional domains of healthcare quality measurement, which is my area, effective care, for example, and patient-centered care, we rank 4th among these countries, basically right in the middle of the pack. That's not where we would expect to be based on how much we're spending. In the domains that focus on efficiency and equity, we're clearly at the bottom of these developed countries. So this is part of the recognition that we're spending more, we're not getting as much as we should, and furthermore, there's been a long-term trend towards increasing government participation in the healthcare system. This is not a function of the current administration. You can see that this graph goes back to 1987, showing consistently over time that private sources have dropped from 68% down to 55% of total health spending. So the government share in the healthcare business nationwide is now up to 45%. And it is projected to increase a bit further to about 49 to 50% as the Affordable Care Act is fully implemented. But this should be viewed as part of a long-term trend rather than as any kind of radical change in the federal role. The other thing that really triggered congressional debate and presidential action on health reform was the recession and the impact of the recession on employer-financed health insurance. We basically lost 11 million people who previously had employer-financed health insurance as a result of the recession. So in 2010, when the act was passed, we were down to 49% of the population that had employer-financed health insurance. That was down from about 60% a decade earlier. The uninsured had risen to about 16–17%. Medicaid programs rose to 17%, Medicare at 12%. So if you look just at the number of uninsured Americans, that rose about 7 million during the recession, about 8 million over the course of the last decade. So we got up to somewhere between 49 and 50 million uninsured Americans. So the combination of these problems really forced some kind of federal action. It was also recognized that these uninsured folks, most of them are actually workers or in working families. So on the right side, 61% of these households had one or more full-time workers, and 16% had one or more part-time workers. In terms of family income, these uninsured households were about split equally between those who were truly poor, below the federal poverty level, those who were near poor, and those who were actually better off. So why is this? What's going on in healthcare and health insurance in particular that leads to these problems? So this is the fundamental economic analysis of what's called market failure. And I want to be clear that this is not some kind of socialist left-wing analysis here. This is basically mainstream health economics. Pretty much everybody who studied the healthcare system and health economics agrees about the nature of these problems. Where we disagree is about how to solve the problems. But the fundamental problems are, first of all, a problem that's known as information asymmetry. What that means, basically, is that you know more about your health needs than anyone else. You know more than your insurance company, specifically. And so that means that all of us are intelligent actors in the economy. We're making decisions that are right for us, but we're making decisions that may be wrong for our insurance company. Okay, so we know something more about how much health care we're going to use next year than our insurance company does. And so insurance companies are very suspicious about our behavior. They worry that when we switch plans, we're switching plans to get a better benefit because we're expecting to use that benefit more in the next year. So this is a problem of asymmetric information. There's also an asymmetry between patients and doctors, because doctors know a little more than you do about your health problems and about the implications of those health problems. Now, that will change, of course, as you go through this course. So, so part of what we're trying to do is to fix that information asymmetry. But one of the consequences of this asymmetry is that there is a phenomenon of supplier-induced demand. What that means is that doctors and hospitals can sometimes, hopefully not too often, but sometimes talk you into things that really aren't a benefit to your health. They can talk you into services that cost money, that bring more money into the system. It's disproportionate to the benefit that you'll gain. So this is called supplier-induced demand for low-value services. It has to do with another problem in economics called the principal agent problem, which is that when you go to the doctor and you use your Medicare benefit and you utilize health services, you're only spending a small portion of that money that's being spent on your behalf. Okay? So other people are making decisions on your behalf, your doctor, your insurance company. So hopefully they're making good decisions, but we do have this problem that you are spending other people's money, essentially. That's the principal agent problem. Doctors are spending other people's money. Doctors are spending your money. Okay, the second problem is moral hazard. So moral hazard basically is a consequence of this first problem. What it means is that if you're insured for something, you're going to use more of it. Okay? That's pretty obvious intuitively, right? So I have a comprehensive car insurance plan. My daughter, she's 17. She's a soccer tournament this morning. She's a great driver. But at school, she parked at school, and somebody messed up the side of the car. Probably a little sloppy parking job, a little body damage. No big deal. Okay? But the cost of fixing it exceeded my deductible. So I decide, well, I'll go ahead and spend the $500 deductible. What the heck? I'll get my $1,500 and I'll pay for the $2,000 in bodywork. If I didn't have that comprehensive coverage, I would have said, am I going to pay $2,000 for this bodywork? No. So I would have made a different decision given an out-of-pocket cost of $500 versus $2,000. So this situation of being insured inevitably increases our demand for the service that's being covered. Okay, finally, there's problems with competition, insufficient competition. So we have in healthcare what economists call barriers to entry. Okay, and that's a bizarre term for the fact that we are licensed professionals, that we have to go through years of medical school, pass exams, go through rigorous training programs, and this gives the profession a way to regulate entry. So we collectively, as a profession, limit the number of people who can become doctors, nurses, the number of hospitals that can open up, so forth. So this creates some limitations in the supply of health professions, unlike, for example, farms, right? So if the price of kiwis goes up, more people will say, well, I'll start making kiwis. And next year, there'll be an increased supply of kiwis, and the price will go down. But we have a problem with a longer pipeline for increasing supply and these barriers to entry. It's also been argued that there's poor antitrust enforcement. In other words, hospitals are allowed to buy each other up, health insurance companies are allowed to buy each other up, and there hasn't been very vigorous protection of competition in the healthcare industry. So these are all causes of market failure. Some people emphasize different things. What are the consequences? Well, information asymmetry leads health insurers to skim the cream, okay, because they're very suspicious about why we're making the choices that we make in the marketplace. So what they do is to sometimes deliberately limit their networks. We see this a lot in the Medicaid plans for children, where they say, oh, we don't have a pediatric cardiologist in our network. I'm so sorry. So what that means is that any child with congenital heart disease has to go to a different plan. Now, isn't that convenient? So that's a way of shifting risk. So plans can avoid the highest risk people and shift them over to other plans. We see selective marketing. Everyone's seen those billboards, right? Thrive. Okay, I like Kaiser. Kaiser's a great organization. But clearly these kinds of marketing campaigns are designed to attract healthy people. They're designed to attract people who are active, people who follow healthy lifestyles. Those are the kinds of people that plans want to get because they know that over the long term, they'll spend less. They try to avoid people who are sick, and they do that by excluding pre-existing conditions. Ah, you have diabetes. You have something that might possibly be related to diabetes. That's not covered. It's a pre-existing condition. So these are the kinds of things people have done. At the extreme, we've even had a problem of policy rescission, which means that somebody's enrolled in a plan, they think they're protected, and then after 6 months, the person's diagnosed with cancer. And they think they're fine, it's a new condition, right? But then what the plan has done in a few cases is to go back and look at the questionnaire that the person filled out when they enrolled, and they found that, that the person reported having no medical conditions, but in fact, they were clearly receiving treatment for allergies prior to when they joined the plan. So now they say, ah, you lied. You're a liar. You lied. You told us that you didn't have any medical problems, but you actually had chronic allergies. So therefore, you committed fraud, and the plan is null and void. We have no obligation to pay for your cancer because you lied about the pre-existing condition. Okay, so that's rescission. Lifetime caps, often $1 million cap. When you reach that cap, sorry, out of luck, you've reached your limit. Maybe you can get some public benefit. So these are the kinds of things that health insurers have done rationally to try to deal with this problem of informational asymmetry. For moral hazard, what insurance companies have done is to deliberately shift more of the burden to us as consumers. Higher deductibles, higher co-payments, give us more skin in the game. That's what the term that's commonly used now. Experience rating. Experience rating means that when my mother, she's a professional dancer, and so she had a dance studio in New York, and she found that she couldn't get any kind of health insurance for her small business. Why not? Because she was a dancer in New York, and it was well known that many dancers in New York developed AIDS. And so that automatically put her in an uninsurable category. So similarly, if you have a bad year as a small business, you could, with experience rating, that experience comes into determining the premium that's set for the next year, just like with car insurance. So that ultimately, of course, drives a lot of small businesses out of the market. Okay, and then market segmentation is about kind of dividing the market into healthier people and sicker people, charging the sicker people more. Finally, insufficient competition leads to a problem that the economists describe as monopoly rent, basically overcharging for services. Okay, so now here's where the controversy is: fixing market failure. So fundamentally, there are three approaches to fixing this problem of market failure. It all comes down to three approaches. And you can call them the liberal or progressive approach, if you will, on top, the conservative approach on the bottom, and what I might refer to as the centrist approach in the middle. So the top and bottom is basically what could have been done that wasn't done. So the top approach is basically to say, well, this is a hopeless situation. We can't fix this market failure, so we're basically going to eliminate or marginalize the insurance market. We're going to treat this as a regulated public utility, essentially. And there are lots of models. This is not an un-American concept. There are lots of models for this. Most of us sent our kids through public school districts, which are created as public entities with public participation and public funding. We had the choice to send our kids to private school. We could opt out of the system, but in fact, public schools remain the dominant method of education in America. Similarly, Medicare is the classic single-payer, single insurance. They bring in commercial carriers as Medicare Advantage plans, as you know. But those Medicare Advantage plans, they have a relatively modest role within the overall scheme. It's a highly controlled federal scheme. Medicaid is a state-federal partnership. Utilities, we're familiar with both publicly owned utilities like SMUD, as well as privately investor-owned utilities like PG&E. So these are single-payer sorts of models where all of this problem with shifting risk and avoiding risk would be eliminated because all the risk would be borne by a single payer. Doctors and hospitals would remain separate and independent. They would continue to bill as they do now, the single payer, but the single payer would set rates either through some kind of a negotiated scheme or through some kind of a competitive bidding scheme. So this was the so-called Medicare for all idea or the single payer idea. At this point, Vermont actually is on the path to implementing such a scheme. Hawaii has a version of it. States do have some freedom to innovate in this area, but this is clearly not the federal approach, and it's not the dominant approach that's going to happen here in California in the near future or across most of the country. The conservative approach is basically to say, well, the reason for market failure is that we haven't truly unleashed the market. How do we unleash the market? Well, that requires eliminating barriers to entry. So it requires allowing insurance companies to sell products across state lines, basically eliminating state regulation of insurance products. It probably requires eliminating some of the professional barriers to entry so that nurse practitioners and PAs can do more of the things that physicians can currently do. It requires providing better information. It requires increasing consumer sensitivity to price through health spending accounts and other devices, basically to make you more sensitive to the price of what you're doing. So that, in fact, if you want to go to a more expensive doctor or a more expensive hospital, you have to pay a lot more for that privilege. That's the idea. So by unleashing the market, we would make consumers really sensitive in the same way that they're sensitive to choices about buying televisions or buying kiwis. and ultimately promoting robust competition through antitrust enforcement and so forth. So this third approach, there's some nice white papers available on it. It has some intellectual attractiveness, but actually it's quite a radical approach in terms of what would be required to really make it work. So what was ultimately adopted in Obamacare, if you will, is a regulatory scheme. So that the means of production are still in the private sector, the insurance companies, providers, but it's becoming a more regulated market. And this was an idea that was originally developed by, actually during the Nixon administration. It has a bipartisan history that dates to legislation that was co-sponsored by Senator Durenberger back in the 80s, I guess, early 80s. It has become more of a partisan issue, but the origin of this idea was actually bipartisan. Fundamentally, it's about a deal. It's about a quid pro quo, if you will, between the government acting on behalf of the people and the insurance industry. And the deal works like this. We're going to prohibit all these undesirable underwriting practices that are designed to shift risk to avoid adverse selection. We're going to limit your profits. And in return, we're going to bring or force healthy people into the market. So this is the deal that basically the insurance industry accepted during the debate over the Affordable Care Act. So these policy rescissions are now banned. Lifetime coverage limits are now banned. Pre-existing exclusions will be banned. Excessive anticipatory premium increases can be regulated by state insurance regulators. And there's a limit called a medical loss ratio, 85%, of how much insurance companies have to basically spend on health services as opposed to retaining for administrative costs or profit. But the quid pro quo is to bring healthy people into the market. How do you do that? Fundamentally by subsidizing low to middle income families and small businesses through the tax system, by encouraging parental coverage of young adults, now up to age 26, and by penalizing or taxing free riders, those who choose not to get health insurance, even when they could participate in this system. And there's been endless debate in the Supreme Court and elsewhere about whether it's a penalty or a tax. I'm not going to go there, but the constitutional question hinges on whether it's a penalty or a tax. So the fundamental principles in the law are to create a new regulated market through state-level health insurance exchanges, where people will receive subsidies up to 400% of the federal poverty level, basically low to middle income people, so that their individual and family contribution to health insurance premiums is limited to about 10% of their gross income. Insurers are now, under this health exchange, will be required to cover anyone, and these underwriting restrictions will be eliminated. Medicaid and high-risk pools will be expanded to cover those who still cannot afford health insurance, particularly those who are below 133% of the federal poverty level. There are some efforts, we're going to talk about more in a few minutes, to constrain Medicare costs and to modestly expand benefits. And finally, there are efforts to promote innovative models of healthcare delivery, what's been described famously by Atul Gawande as an agricultural extension service for healthcare, where the idea is to fund some pilot programs across the country, some innovative models, to see what works in terms of reducing costs and cost increases over the long term. And then whatever is shown to work can then be spread across the country. So these are the fundamental principles. Quick slide on historical analysis. So most of us are old enough to remember that this was tried before during the Clinton administration. Bill Clinton, Hillary Clinton famously developed a fairly similar health reform proposal that failed. And so there's been a lot of analysis in the political science community about why it failed, what happened, why it succeeded this time. generally, the arguments that are put forward about why previous efforts failed, number one is the opposition of key stakeholders. Insurance industry opposition, many of us may remember that the airwaves were blanketed with these Harry and Louise commercials about people panicking about what the implications of the Hillary Clinton health plan would be. And basically, what was done in the last 3 years was that this opposition was silenced through this kind of a comprehensive deal, if you will, with the industry that I previously described. The other problem was they had a White House-driven approach. They brought in the experts, and as a result, they kind of lost a lot of time during a critical year. A lot of opposition was able to form, and then the president sort of handed it on a silver platter to Congress. So Congress doesn't like that, right? They like to wheel and deal and argue about all the little provisions. And so this time Obama basically kind of left it up to Congress. He said, well, these are the basic provisions of what I'll sign. You guys work out the details, and that's what they did. But it was a very strange process of sausage making. Those of you who study the political process. So basically there were 5 different bills, 3 coming in the House, 2 in the Senate, that had to be all put together. The House operates under sort of benign dictatorship rules, so they allow virtually no discussion or amendments. The majority party rules. They lost a fair number of Democratic votes, squeaked through with a vote of 220 to 215. On the Senate side, they have a little bit more collegial open process, but still they barely squeaked by 60 to 39, requiring 60 votes to cut off filibuster for cloture. And just then, the Massachusetts Senate seat turned over, so they lost their 60-vote majority, got down to 59 votes. So the usual process by which a compromise bill would have come back to both chambers couldn't happen because they wouldn't have gotten the 60 votes. So basically the House had to gulp and swallow the Senate bill whole because the conference bill couldn't go back to the Senate. So as a result, there was a reconciliation bill that had to be passed later to clean up some mistakes in the Senate bill. So it was an odd process, but nonetheless, it did pass. So what's going to happen? What's going to happen and how it's going to affect Medicare? So what we're going to see, and these are the best projections that I can offer, what we're going to see is an increase in roughly 13 million Americans who will get onto Medicaid programs. It may be a bit less because of the Supreme Court decision, which gives states more flexibility in that area. The individual coverage through the health insurance exchanges will increase by about 19 million. The number of uninsured will drop by about 30 million. Remember, we started with 49 million, so this will still leave about 20 million uninsured, but it's a huge change. Now, there are many provisions related to Medicare. Basically, the result of those provisions is about $105 billion in new Medicare spending and a larger amount of new Medicare revenue. We'll talk about that in a minute. What is that new money being spent on? The largest chunk of it is being spent to reduce the Part D donut hole. I'll explain that in a minute. A smaller chunk for improved prevention benefits, annual wellness visits, and a smaller chunk for improved payment for primary care physicians. Okay, so here's how the Part D prescription drug benefit works. And this is a doozy, but this was how it was enacted in the original bill that created Part D during the George W. Bush administration. So basically there's a deductible of annual deductible of $310, which is paid by the enrollee. Then you kick in with a 25% copay. 75% is paid by your Part D plan, up to a total currently of $2,830 in total drug costs. Then you hit what's referred to as the donut hole, where you are fully responsible for 100% of your prescription drug costs until you reach a catastrophic level of $6,440, at which point your contribution drops to 5%, and the plan pays 95% with an 80% contribution from the generosity of the federal government. So this is the current scheme. What's going to happen? Well, when the new prescription drug benefit is fully implemented, basically you will have 25% copay all the way up to the catastrophic limit. Now, these limits are adjusted each year with inflation, but you can see that this donut hole will essentially be closed. And it'll be closed in two ways. One is by, with generic drugs, it'll be closed in the usual way. You pay 25%, the plan pays 75%. For brand name drugs, it's going to be closed by forcing the manufacturers to cut their price by 50% to give you a 50% discount, and then it's an even split with the plan at that point. So this is, again, was all part of the negotiation, and the brand name pharmaceutical manufacturers basically accepted this 50% discount as a price for selling more of their product. Okay, so there is some savings involved for the Medicare program as well. So provider payments will be cut by $219 billion. These are principally payments to hospitals, what are known as DISH payments. And you know, this got a lot of press during the presidential election. There was talk about $700 billion in Medicare cuts. So I'm going to briefly explain what that really means. So these DISH cuts, so the deal here is that this is kind of a weird scheme that Medicare has had to compensate hospitals for taking care of people without insurance. So basically the federal government says, we know that some hospitals are really impacted by all these people without insurance. So we're going to overpay you for your Medicare patients to make up for these uninsured people. Okay? So that, you know, it makes sense, and it allows public hospitals to continue to exist. But it's a screwy scheme from the economic standpoint. So the idea is that as these uninsured people gain insurance, then this subsidy needs to be reduced, right? Because this is a backhanded scheme that really shouldn't be part of the Medicare program. There should be a more direct scheme for uninsured people to pay for their hospital care. So most of this reduction is in these DISH payments to hospitals that will be less necessary as there are fewer uninsured people. $136 billion is reduction in Medicare Advantage payments. More on that in a minute. $36 billion comes from increased premiums for Part B and Part D, particularly the income thresholds for those premiums. $16 billion comes from an independent payment advisory board that's empowered to make recommendations in the future for other creative ways to reduce provider payment. And then finally, $12 billion comes from some specific reforms related to reducing hospital readmissions. Okay, so a little bit more on Medicare Advantage. Most of you who are in the Medicare program have a choice of the fee-for-service traditional Medicare program or a Medicare Advantage plan. Nationwide, 27% of Medicare enrollees are in Medicare Advantage plans. But here in California, it's about 50%, so we're a lot higher than the national average. Medicare Advantage enrollment has increased substantially over the past decade, up to 11 to 12 million now. The point here is that Congress deliberately overpaid insurance plans to bring more insurance plans into the market, to encourage them to offer Medicare Advantage plans. This was well known as a matter of public policy. A deliberate effort to bring more plans into the market, and specifically to encourage plans to offer products in areas that can't normally support HMOs or PPOs. So rural communities, smaller communities that tend to be higher cost communities in general, where there isn't a lot of competition, and hospitals can historically charge more actually than they can in large metropolitan areas. So basically, Congress said, that's okay, we're gonna overpay a little bit, 5% or so, so that there's more incentive for private plans to come into this market. But the market is now mature, and so the argument is that this subsidy should be reduced. And that's what the Affordable Care Act does, is progressively to reduce these overpayments, basically to link the amount that Medicare pays on your behalf, if you choose a Medicare Advantage plan, to what Medicare would have paid in your county if you had opted out of Medicare Advantage, if you had stayed in the traditional fee-for-service system. So Medicare will now be neutral to your choice of whether to enroll in an HMO or a health plan, a Part C plan. Okay, so what are the implications for beneficiaries? So these are the total excess payments to Medicare Advantage plans above and beyond what people would have spent in the fee-for-service market. And so we've already seen some reduction under a previous bill from 11 billion down to about 9 billion. And gradually this will be whittled down to basically reverse the increase that's happened over the previous decade. Okay, I won't get in. Okay. So anyway, the concern, of course, is that there may be some impact on beneficiaries. So the personal financial advantage to you to join a Medicare Advantage plan is likely to decrease. Okay? So currently, if this is a little too complicated for me to explain, but the bottom line is that some of the marginal benefits that you get from joining an MA plan will decrease. And so more people may opt to stay in fee-for-service. This is a brief synopsis of the delivery system reforms, including a variety of efforts to engage providers in shared savings plans, to reduce payments for potentially preventable hospitalizations or readmissions, to pay hospitals, nursing homes, doctors more for providing higher quality care, so-called value-based purchasing, to reduce payments when patients experience complications. So these are all relatively marginal in terms of the impact of spending, but the idea is really to motivate physicians and hospitals to behave differently and to spend federal resources more responsibly. I'll briefly touch on this Independent Payment Advisory Board. It really doesn't kick in until 2015 at the earliest, but the idea is that if our increases in Medicare spending continue to exceed benchmarks based on economic growth, then we'll need some additional recommendations about how to slow the growth. And so this board is empowered to offer recommendations as long as they don't have anything to do with reducing benefits, increasing cost sharing, changing eligibility premiums or taxes. So it all has to be about the payment side rather than the benefit side of the Medicare program. There are additional revenue sources. So those of you who pay a Part B premium, there's an annual indexing of an income threshold where if your income is above 85 for an individual, 170 for a couple, you have to pay a higher premium. That threshold will no longer be increasing over the next 8 years. So it'll stay fixed at 85, 170. There will be a new Part D premium, very similar, that will be implemented. So those of you who have Part D plans, if you're above 85, 170, you'll have to pay a little bit more for your Part D plan. Those of us who are employed, if we earn over 200K as an individual or 250K as a couple, there will be an increase in our payroll tax for Medicare Part A. The impact of this will be a prolongation of the life of the Medicare Trust Fund. So pre-Affordable Care Act, the Medicare Part A Trust Fund was expected to run out of money in 2017. Post-Affordable Care Act, the expected insolvency date is 2029. So that makes me feel much better. Here's another way of looking at that. So this is how Medicare spending would have increased, according to the actuaries, absent the Affordable Care Act, an average of 6.8% per year. And this is how it is now expected to increase 5.5% per year. So that gap, if you will, represents the savings to the Medicare program as a result of the Affordable Care Act. Okay, skip over that. Okay. Okay, so final couple of slides here. So the Affordable Care Act has, as you can see, included some specific features that will improve your benefits, particularly for Part D if you're in the Medicare program. It may increase your cost, especially if you're at the higher income side, over $85 for an individual, $170 for a couple. But we have to view this in a larger context, okay? So as the previous slide, the 2026, illustrated, the Medicare program is still in trouble. It's gotten a little bit of a breathing room, but the program is still in trouble. And why is it in trouble? It's in trouble because of increasing enrollment. Those of us like Cal and me, who are in the baby boom generation, we may postpone our retirement, we may stay active, but eventually we will retire and we will collect Medicare. And then the program's going to be in big trouble. So this is the increase that we've seen in Medicare enrollment. The oldest folks in the baby boom generation now retiring, we're up to 47 million, close to 50 million now in 2012 in the Medicare program. People in the Medicare program generally are happy. They like their benefit. If you ask them about the quality of their health insurance, in fact, only 8% are dissatisfied as opposed to 33% in individual health insurance and 20% in employer finance plans. Relatively few complain of problems with medical bills. So the Medicare program has been a tremendously popular program. How do we protect that program going forward? This is the consequence of baby boom. We're going up to 80 million Medicare beneficiaries by 2030. And as we go to that increase, the number of active workers per beneficiary will decrease from 4 to 3.4 now, down to 2.3. So this is the number of people who are paying Medicare payroll taxes versus the number of people who are actually receiving Medicare benefits. And why is this a problem? This is a problem because the financing of the Medicare program doesn't work like a lot of people think it works. A lot of people think that it's some kind of like a 401k that you pay into for all this time and then you get the benefits later. That's not how it works. It's a transfer program. So today's workers pay for today's retirees. Only 4% of the total spending on the Medicare program, only 4% comes from interest and investment income from the trust fund. 96% comes from federal and state revenues, 40% from general revenues, and 38% from payroll taxes on today's workers. So this is the challenge that we face going forward. And furthermore, if you look at the projected growth in federal spending on the Medicare program, according to the actuaries, it looks something like this. And only part of this is from aging. A big part of it is from excess cost growth. So what this means is that we have to figure out ways to make healthcare more efficient. So this is going to hurt. It has to hurt. For those of us who are providers who work in the system, we're going to have to figure out ways to deliver care smarter, to deliver better care for less money or less of an increase each year. Or else we're going to we collectively as a healthcare system are going to drive the country bankrupt. So Secretary Sebelius was quoted last week saying that this implementation of the Affordable Care Act that she's responsible for is like synchronized swimming. There's a lot of focus on the bathing caps, but there are a lot of things happening under the surface. And her foil, who's a Republican congressman from Texas, said, no, think of synchronized swimming going over Niagara Falls. That's what the implementation of the Affordable Care Act is really like. So we'll see what happens over the next 2 years. It's an exciting time, and we'll see what happens together. Thank you very much.
Thank you very much, Dr. Romano. We have literally time for a couple of questions so that you can get your bathroom break. So anyone, there's a question at the upper end. Anybody with a microphone to help out? I guess no one is running around with the microphone. Go ahead and try, and I'll see if I can repeat your question.
Someone, why don't you go up to the front? He's
oh,
right
okay.
here.
Actually, I was going to the back.
Okay, sorry. I just wanted to get a microphone.
Go ahead. Go ahead.
Is part of the reason healthcare is more expensive in the U.S. than the European countries because we're so spread out in so many rural areas?
Is part of the reason that American healthcare is more expensive than in Europe because we are so spread out and have so many rural areas?
It could be. It is one of the factors. Healthcare in rural areas tends to be more expensive on average, but it's a very small piece of the overall situation. In other words, our population is still over 90% urban or suburban, and the differential in healthcare costs is only in the range of 5 to 10%. So it's only a small piece of it.
Thank you, Dr. Romano. We'll see you back in 10 minutes.